Picture a 32-year-old woman rush into the emergency room. She has severe abdominal pain. She's dizzy, and her heart rate is racing at like 115 beats per minute.
Right, and her blood pressure is completely bottomed out at 90/50.
Exact. Oh, and it's been 6 weeks since her last period. If your brain didn't immediately flash red and scream ectopic pregnancy until proven otherwise, well, then you are exactly where you need to be today.
Because in that specific scenario, the patient is experiencing hypovolemic shock. Her heart is just pumping furiously to compensate for massive internal bleeding.
Probably from a ruptured fallopian tube.
Yes, highly likely. And it's a literal life or death scenario where the underlying anatomy is completely hidden from the naked eye.
Welcome to the deep dive. Whether you are, a medical student prepping for boards, maybe a young healthcare professional refining your clinical reasoning, or just an insanely curious mind, we are thrilled to have you with us.
Absolutely thrilled.
Today, our mission is to provide a really comprehensive educational summary of the foundational concepts in gynecology. We are taking the core principles, the kind you'd find in gold standard texts like Gynaecology by 10 teachers, specifically the 20th edition, and translating them into a working mental model.
Yeah, and we are not here to just recite a list of symptoms and drugs, right?
Definitely.
Rote memorization just fails at the bedside. We are going to explore the underlying mechanisms. You really need to synthesize how a patient's hidden anatomy and her shifting hormones actually dictate the medical management you choose.
Right, because if you understand the why and the how, the diagnosis basically reveals itself naturally. Okay, let's unpack this because we are going to journey through the entire female reproductive life cycle today.
It's a huge topic.
It really is. We'll start with the art of the clinical consultation, dive deep into the chemical wizardry of endocrinology, and navigate all the way through to complex surgical interventions.
So let's start at square one, which is the clinical consultation. Before you touch a single instrument, you have to navigate the patient's lived experience.
You're building that structured history.
Exactly. Menstrual cycles, sexual history, contraceptive use, cervical smear records. But it's not just data collection. You are asking incredibly intimate questions.
Right.
Which means the patient's psychological reaction to your questions is actually a vital diagnostic clue in itself.
If we connect this to the bigger picture, the consultation room is where you establish psychological safety, right?
Yes, 100%. An extreme reluctance to undergo a vaginal examination, even with a highly qualified, gentle practitioner, isn't just a patient being difficult or non-compliant.
Oh, wow, no.
It is often a glaring indicator of underlying psychological trauma. A clinician really must maintain a high index of suspicion for realities like female genital mutilation, or FGM.
Yeah, understanding the profound cultural and psychological context of FGM is completely non-negotiable for anyone in this field. Just to convey the ideas from our source material today, seasoned practitioners often turn to literature, like Alice Walker's novel, Possessing the Secret of Joy.
Right. That book is specifically recommended in the text.
Yeah, to truly grasp the lifelong emotional and physical devastation FGM inflicts, it goes way beyond what clinical bullet points can ever really convey.
It absolutely does, and that reframes the consultation entirely. It's a detective's intake interview where empathy is your primary tool.
The history tells you exactly where to shine your flashlight during the physical exam. And when it is time for the physical examination, the tools and techniques have to be super precise. You're using, like, a Cusco's speculum.
That's the duck-billed one, right?
Exactly, to visualize the cervix directly. Or a Sims speculum, often with the patient resting on her left side to hold back the vaginal walls. But the real structural mapping happens during the bimanual examination.
Yeah, the bimanual exam is essentially trapping the pelvic organs between your two hands to assess their architecture.
Right.
By inserting 2 fingers into the vagina, while the other hand presses firmly down on the abdomen, just above the pubic bone, you can actually palpate the uterus.
You are assessing its size, its mobility, and crucially, its position. You need to know if the top of the uterus is tilting forward toward the bladder, which is anteversion, or tilting backward toward the spine,
which is known as retroversion.
Right. I always used to wonder why charting the exact tilt of the uterus mattered so much if it's just, a normal anatomical variation. But there is a massive mechanical and surgical implication here, isn't there?
Oh, massive. What's fascinating here is how this simple physical finding directly dictates surgical safety. Imagine you are about to perform a procedure that requires dilating the cervix.
Like to clear the uterine lining.
Exactly. You have to pass a rigid metal instrument through the cervical canal. If the uterus is retroverted, tilting backward, but you blindly assume it's tilting forward like the majority of patients? Well,
You'd push that instrument straight through the muscular wall of the uterus.
yes. Determining anteversion versus retroversion immediately prior to operations requiring cervical dilation is literally how you prevent catastrophic uterine perforation.
That is such a brilliant example of anatomy directly driving practice. So once we've mapped out the physical structure, we have to look at the chemical drivers regulating it. The female reproductive system runs on an incredibly complex feedback loop.
The hypothalamo-pituitary-ovarian axis, the HPO axis.
Yeah. The hypothalamus pulses gonadotropin-releasing hormone, which tells the pituitary to release follicle-stimulating hormone and luteinizing hormone.
And those in turn tell the ovaries to produce estrogen and progesterone. It is a masterful symphony of chemical signaling. And the most visible outcome of that symphony is menstruation.
Right.
But the mechanism of menstruation is often really misunderstood. It is fundamentally an ischemic event.
Wait, an ischemic event, meaning it's driven by a lack of blood flow.
Precisely. The endometrium, which is the lining of the uterus, has two main layers. The bottom layer is the stratum bassalis. That's the permanent foundation.
Okay.
The top layer is the stratum compactum, and that thickens every month to prepare for a fertilized egg. When an egg isn't fertilized, progesterone levels completely plummet.
And what does that sudden hormone drop do?
It causes the spiral arterioles, the tiny blood vessels supplying that top layer, to violently constrict. This vasoconstriction literally starves the stratum compactum of oxygen.
Oh, wow.
Yeah, the tissue undergoes ischemia, dies, and sheds off. That is the biological reality of a period.
So a period is essentially the controlled, synchronized death of that top tissue layer due to oxygen starvation. That makes total sense. But what happens when that chemical symphony falls out of rhythm?
Well, we see conditions presenting like oligomenorrhea, which means infrequent periods.
Let's look at a classic clinical presentation you'll see in practice. A 22-year-old woman comes in. She's struggling with irregular periods. She has noticeable excess facial hair, severe acne, and a body mass index of 30.
That specific triad of symptoms is the absolute hallmark of polycystic ovary syndrome, or PCOS. And understanding the mechanism here is crucial.
So break that down for us.
The excess facial hair and acne are signs of hyperandrogenism, which means too much testosterone. The irregular periods point to an ovulation, meaning her ovaries just aren't releasing eggs regularly.
And how does the elevated BMI fit in?
It ties into the root cause, which is insulin resistance. High insulin levels actually stimulate the ovaries to produce those excess androgens, which in turn halts the normal maturation of ovarian follicles.
So it's actually a metabolic issue manifesting as a gynecological one.
Exactly.
Which means treating PCOS requires a metabolic approach, not just handing over a birth control pill and calling it a day.
Right.
On the flip side of infrequent periods, we have abnormal uterine bleeding and heavy menstrual bleeding.
By AUB and HMB.
When a patient is bleeding far too much, we look for structural causes. Things like fibroids, which are benign, non-cancerous tumors growing in the muscle wall of the uterus, or adenomyosis. But let me challenge the diagnostic process here. If a patient is sitting across from you complaining of heavy, agonizing periods, how do you distinguish between a purely hormonal misfire and a physical roadblock like a fibroid just from talking to them?
That's a great question. You listen for symptoms of physical displacement. Hormonal issues, like the anovulation we just discussed, they create unpredictable, chaotic bleeding patterns because the lining builds up erratically and breaks down erratically.
Makes sense.
But a fibroid is a dense ball of muscle. It takes up physical space in the pelvis. So a patient with a large fibroid might complain that she has to urinate constantly.
Because that enlarged uterus is pressing directly on her bladder.
Exactly. Or she might report a chronic feeling of heaviness or abdominal fullness.
And does adenomyosis present differently on physical examination?
It does. In adenomyosis, the inner lining of the uterus actually grows deep into the muscular wall itself. So during that bimanual examination we talked about earlier, instead of feeling a firm, lumpy fibroid,
You feel something else.
yeah, the clinician feels an enlarged, tender, boggy, or spongy uterus because the whole muscle wall is inflamed and bleeding internally every month.
Ouch. And to confirm either of these,
Transvaginal ultrasound, or TVUSS, is the gold standard. By placing the ultrasound probe in the vagina, you get mere millimeters away from the uterus, providing highly accurate, inexpensive imaging of the internal architecture.
the ultrasound is like the ultimate flashlight. Now, understanding this menstrual cycle naturally forces us to look at the clinical management of its biological purpose. reproduction.
Right. Sometimes a patient is trying to prevent it, sometimes they're trying to achieve it, and sometimes you are managing complications in early pregnancy.
Let's start with prevention. We have long-acting reversible contraception, or LARC.
LARCs are the absolute gold standard for efficacy because they just remove human error entirely. The copper IUD is fascinating because it works by releasing copper ions that create a highly toxic inflammatory environment for both sperm and eggs.
Which prevents fertilization entirely.
Yes. Importantly, because of this immediate toxic effect, inserting a copper IUD is the most effective form of emergency contraception available if used within 5 days of predicted ovulation. There's also the levonorgestrel intrauterine system, the LNG-IUS, which uses hormones locally.
Contrast that with combined hormonal contraception like the traditional pill or the patch. The mechanism there is pure chemical hacking. The pill provides a steady dose of synthetic estrogen and progesterone.
And that creates a negative feedback loop on the pituitary gland.
Right. The pituitary senses these high hormone levels and thinks, we must already be pregnant, so it completely stops releasing follicle-stimulating hormone and luteinizing hormone.
Yes, and without those signals, the ovary never wakes up and no egg is ever released. It effectively pauses the ovarian cycle.
But what happens when the goal is conception and the biological machinery just isn't cooperating?
Well, we define subfertility as the failure to conceive after 12 months of regular, unprotected intercourse, and it is incredibly common.
It affects roughly 1 in 7 couples, doesn't it?
It does. And it is a dual patient issue, meaning investigation must always be couple-centered.
Here's where it gets really interesting because diagnosing subfertility is kind of like troubleshooting a complex manufacturing and a delivery line. You have to check every single checkpoint.
Definitely.
For the male partner, you start with a semen fluid analysis, the SFA, to ensure the product is actually being made and has mobility. For the female partner, you have to check the delivery pathway's tubal patency.
Right. Are the fallopian tubes open? Or are they scarred shut from a previous pelvic infection?
And you must assess the ovarian reserve.
We do this by measuring anti-Müllerian hormone, or AMH, in the blood. AMH is secreted by the small developing follicles in the ovaries. So a higher AMH level generally indicates a larger remaining pool of eggs.
So following that manufacturing analogy, the treatment depends entirely on where the breakdown is. If the male partner has a severely low sperm count, simply placing the sperm in the uterus intrauterine insemination, or IUI, well, that won't work well.
No, it won't. You have to bypass the factory floor entirely and move to in vitro fertilization, IVF, or even intracytoplasmic sperm injection.
ICSI.
Yes, where an embryologist injects one single viable sperm directly into the egg under a microscope.
Bypassing compromised physical pathways is just a marvel of modern medicine. But compromised pathways in a natural pregnancy can lead to catastrophic outcomes, which brings us right back to the patient in the emergency room we discussed at the very beginning.
Ah, yes.
Yeah.
The 32-year-old with cardiovascular instability, a positive pregnancy test, and a 6-week timeline.
The ectopic pregnancy.
Yes. When a fertilized egg implants outside the uterine cavity, most commonly in the narrow tube of the fallopian pathway, it begins to grow in a space that simply cannot expand.
And as the embryo invades the tubal blood vessels,
It eventually causes the tube to rupture. This results in massive hemorrhage into the abdominal cavity. The patient's blood pressure drops dangerously low, and her heart races to compensate for the lost blood volume.
it requires immediate life-saving surgical intervention to stop the bleeding, which perfectly illustrates the stakes. Gynaecology isn't just outpatient clinics. It is acute, life-saving surgery.
It absolutely is.
Now let's shift gears. Just as the reproductive years bring these intense, specific challenges, the cessation of ovarian function and the natural mechanical aging of the pelvic floor introduce an entirely new clinical paradigm.
The field of urogynecology deals heavily with this post-reproductive mechanical breakdown. Urinary incontinence is a massive quality of life issue.
Oh, huge.
And differentiating the type of incontinence is paramount because the mechanisms and treatments are polar opposites. Let's look at stress incontinence first. This is a purely structural failure.
Right, this is the patient who leaks urine when she coughs, laughs, or lifts something heavy.
Exactly. The pelvic floor muscles and the urethral sphincter have weakened, often due to childbirth or the drop in estrogen during menopause. When abdominal pressure increases, the sphincter simply cannot hold the seal.
And if pelvic floor exercises fail.
The treatment is mechanical. Surgeons can place a mid-urethral synthetic tape to physically support the urethra, acting like a backstop when pressure spikes.
But that structural fix would do absolutely nothing for the other major type. Overactive bladder or detrusor overactivity?
Nothing at all, because the mechanism there is neuromuscular, not purely mechanical. In overactive bladder, the patient experiences sudden, uncontrollable urges to urinate, often accompanied by frequency, because the detrusor muscle, the muscle wall of the bladder, is spasming and contracting inappropriately.
And the medical treatment for that.
The first-line medical treatment relies on anticholinergic drugs.
Let's break down how those actually work.
The neuromuscular junction of the bladder relies on a neurotransmitter called acetylcholine to trigger a contraction. Anticholinergic drugs bind to the muscarinic receptors on the bladder muscle.
Physically blocking the acetylcholine from attaching.
Exactly. By antagonizing these receptors, the drug prevents the detrusor muscle from contracting prematurely, and it also dulls the afferent sensory nerve signals that tell the brain the bladder is full.
It's like it just cuts the electrical wire to the spasming muscle.
That's a great way to put it.
Moving from the lobopelvic floor to the whole body, we really have to talk about menopause. Menopause is officially defined as the irreversible depletion of ovarian oocytes.
Right. No more eggs means no more estrogen. And estrogen isn't just a reproductive hormone. It is a vital structural protector for the entire body.
The systemic shock of losing estrogen is profound. In the skeletal system, estrogen normally keeps bone-destroying cells called osteoclasts in check.
Without estrogen, osteoclasts just run rampant, rapidly accelerating the loss of bone mineral density and leading to osteoporosis.
And in the cardiovascular system, estrogen helps keep blood vessels flexible and healthy. Its withdrawal leads to a sharp spike in cardiovascular disease risk for women.
Which inevitably brings us to the incredibly controversial topic of hormone replacement therapy, or HRT.
Oh boy, yes. Anyone who has studied medicine in the last 20 years knows about the Women's Health Initiative, the massive WHI study from the early 2000s. And just reporting objectively on what the sources outline here, that study basically terrified the world by claiming HRT increased cardiovascular disease.
It did.
Wait, so if the WHI study showed reductions in survival from CVD, why is HRT still prescribed for cardiovascular benefits in some women?
That paradox is one of the greatest lessons in how to critically appraise medical literature. The WHI study's conclusions terrified the public, but its methodology was deeply flawed for the questions it was trying to answer.
How so?
The researchers gave HRT to a population of women who were, on average, over a decade past their menopause. These were older women, many of whom were overweight and already had significant silent cardiovascular disease.
So they were giving hormones to women whose arteries had already been hardening for 10 years.
Precisely. If atheroma plaques fatty deposits have already formed in the arteries, introducing oral estrogen can actually destabilize those plaques and increase clotting risk.
Which leads to heart attacks.
Yes, but our current physiological understanding is based on the window of opportunity hypothesis. If a woman starts HRT during the perimenopause or very early postmenopause, the estrogen acts preventatively.
It stops the atheroma plaques from forming in the first place.
Exactly, thereby reducing long-term cardiovascular morbidity. You just cannot blindly apply data from an older, higher-risk population to a healthy 50-year-old experiencing hot flushes.
Context completely flips the medical management. Now, as we enter our final segment, we must address what happens when these cellular mechanisms go rogue.
When benign conditions escalate or cellular changes mutate into malignancies, the clinician must pivot to critical oncology and major surgery.
Let's map out the big three gynecological cancers. We begin with endometrial cancer, which is cancer of the uterine lining.
It is the most common gynecological cancer in developed nations, and it has a direct mechanistic link to obesity and type 2 diabetes. Adipose tissue body fat contains an enzyme called aromatase.
And that enzyme converts circulating androgens into estrone, a type of estrogen. So adipose tissue acts like a secondary estrogen factory.
Yes, and because this patient is often anovulatory or postmenopausal, she is not producing progesterone.
Which is the hormone that stabilizes and thins the uterine lining.
Right. Without it, you have unopposed estrogen constantly fertilizing the endometrium. The cells multiply uncontrollably, which eventually mutates into cancer.
And the glaring clinical red flag for this is postmenopausal bleeding.
If a woman who has gone through menopause suddenly bleeds, it is endometrial cancer until proven otherwise.
Then we have cervical cancer, which is fascinating because it is almost entirely an infectious disease, giving us a robust prevention framework.
The vast majority of cervical cancers are caused by high-risk strains of the human papillomavirus, or HPV. Primary prevention is simply vaccinating against the virus before exposure.
But secondary prevention is where the anatomy gets interesting. During a cervical smear test, the clinician is sampling cells from the transformation zone.
That's the volatile border on the cervix, where the rugged squamous cells of the vagina meet the delicate glandular cells of the cervical canal. Because this zone is constantly turning over, it is highly vulnerable to HPV hijacking the cellular DNA.
And if a pathologist spots those precancerous changes on the smear, how do we fix it before it becomes invasive cancer?
We use a procedure called LLETZ, which stands for large loop excision of the transformation zone. The surgeon uses a thin wire loop carrying a high-frequency electrical current.
To simultaneously cut and cauterize.
Yes, scooping out that entire volatile border of precancerous tissue while leaving the healthy cervix intact.
It's an incredibly elegant, localized cure. But ovarian cancer does not afford us that luxury. It's infamous for being a silent disease.
Because the ovaries sit free-floating in the expansive pelvic cavity, a cancerous tumor can grow to the size of a grapefruit before it pushes against other organs.
And causes symptoms like persistent bloating or a change in bowel habits.
By the time it's caught, it is often spread. Diagnosis involves an ultrasound to look at the mass and a blood test for a tumor marker called CA-125. These are combined to calculate the risk of malignancy index, or RMI.
So what does this all mean for the clinician preparing a patient for such a major operation? When dealing with these severe pathologies or even massive benign conditions like life-altering fibroids, the definitive surgical endpoint is often an abdominal hysterectomy.
Right. The physical mechanics of removing a uterus require systematically clamping, cutting, and tying off three main vascular and structural pedicles on each side: the round ligament, the adnexal structures connecting to the ovaries, and the main uterine blood vessels.
How do you manipulate the body to make that surgery safer?
Use the endocrinology we discussed earlier to your surgical advantage. If a patient has a uterus massively enlarged by fibroids, a surgeon might prescribe a GnRH agonist for 3 months before the operation.
This drug overstimulates the pituitary gland until it exhausts itself and shuts down, plunging the patient into a temporary reversible menopause. By aspiring the fibroids of estrogen, they shrink.
Exactly. The reduced bulk and decreased blood flow mean the surgeon can use a much smaller, safer, transverse Fanon-style incision low across the bikini line instead of a massive vertical incision.
Oh, that makes a huge difference for recovery.
It does. But this raises an important question regarding consent and risk. Any major pelvic surgery carries a massive risk of deep vein thrombosis, or DVT. The pelvic veins are manipulated, the patient is immobile during recovery, and blood pools in the legs.
So post-operative care must rigorously include thromboprophylaxis.
Like injecting low molecular weight heparin to thin the blood and prevent a clot from traveling to the lungs.
It is a phenomenal journey. We have gone from the psychological nuance of the clinical consultation through the ischemic mechanism of a period into the plumbing of subfertility, the systemic shock of menopause, and finally the high-stakes engineering of oncology and pelvic surgery.
If you've absorbed the mechanisms behind all of this, you are well on your way to mastering the foundations of gynecology.
Let's put that to the test with a rapid-fire clinical scenario to review our pharmacology.
All right, here's the scenario directly from the text. A 45-year-old woman presents with a 3-year history of urgency, urge incontinence, and leaking urine 4 times a day. She wears sanitary pads constantly. Her BMI is normal, but pelvic floor strength is weak. What is the pharmacological mechanism of the first-line medical treatment she should receive?
Okay, let's think about the symptoms for a second. The sudden urgency and leaking point away from a structural stress leak and toward a neuromuscular spasm.
Which means?
The diagnosis is overactive bladder, so she needs anticholinergic medications. And the mechanism is that the drug physically blocks acetylcholine from binding to the muscarinic receptors on the bladder wall, which cuts the chemical signal and stops the detrusor muscle from spasming.
Spot on. You've isolated the symptom, identified the tissue misfiring, and applied the exact molecular fix. But before we sign off, I want to leave you with a provocative thought that pushes the boundaries of everything we've discussed today regarding menopause. We are taught that menopause is the irreversible depletion of a set number of eggs a woman is born with. But recent groundbreaking research has identified ovagonial stem cells from primordial follicles within the ovaries.
Wait, actual stem cells capable of creating new eggs?
Yes. If these primordial stem cells can be fully understood and harnessed, it suggests the ovary isn't just a declining bank account of oogocytes. It might eventually allow medical science to proactively influence the actual timing of menopause. Imagine how controlling the systemic aging process of half the population would completely rewrite the landscape of this entire textbook for future medical students.
That fundamentally changes how we look at human biology. It proves that even the most deeply entrenched dogmas in medicine are just waiting for the right researcher to ask why. Thank you for joining us on this deep dive. As you head back to your clinics, your wards, or your textbooks, remember that the diagnostic landscape of gynecology might seem murky at first glance. But armed with a sharp history and a relentless focus on the underlying mechanisms, you can navigate those waters with absolute clarity. Keep asking why and keep diving deep.